All right. So tonight we are going to cover disorders of the nervous system. I will point out um, the slides weren't up on Moodle. The slides that I received for the nervous system disorders, the slides that I received were just not up to my standards. So I had to spend a lot of time kind of remaking them. So I hope you appreciate them. They are now on Moodle live and in living color. So before we talk about the nervous system disorders, it is always super helpful to start with a review of the nervous system itself and just kind of remind ourselves of mainly the vocabulary, the general idea of what the system is doing, what its function is. So we will start with the functions of the nervous system. Mainly are to coordinate, control, regulate all of your bodily processes. This would be controlling all of your internal as well as external movements. So internal movements, we're thinking about things like heartbeat and peristalsis, keeping your food moving through the digestive tract, but we're also talking about the smooth muscle actions in your blood vessels and in the walls of glands, smooth muscle in the lining of a uterus during contractions. There's a lot of internal movement going on. The nervous system also functions for memory, sensation, all of your senses, sight, hearing, smell, emotions, and cognition. We'll recall the basic building blocks of the nervous system are neurons. Neurons are specialized cells that have branching extensions or processes off of their cell bodies. The shorter appendages are called dendrites. The long appendage is called the axon. The nervous system is comprised of three primary structures, that is the brain, the spinal cord, and the peripheral nerves. So the brain and spinal cord together comprise the central nervous system. All the nerves are the peripheral nervous system. The brain has four main structures that we look at: cerebrum, cerebellum, diencephalon, and the brainstem. The first one we're going to recap is the cerebrum. So the cerebrum is the outer layer of the brain. This is the part that you're usually thinking of when you think about the brain. It's kind of pink, it's noodly looking, it's got all little wrinkles on it. This is the cerebrum. The cerebrum is divided into four lobes. The frontal lobe, right behind your forehead, deals with all of the really fancy human stuff like problem solving and multi-stage planning, and this is where your personality sits. The parietal lobe, back in the back, deals with sensory and somatic integration. So integrating all of the data that the body is collecting about pressure and temperature and joint movement so that the brain has a constantly updated model of where the body is in space and what the body is doing. The occipital lobe, the entire department is specialized and dedicated for visual processing. Just seeing what you're interpreting, what your eyes see. We have the entire occipital lobe for that. And finally, the temporal lobe, which sits right over your ears. So that's where hearing is processed, as well as speech and expression. This is also where the hippocampus lies. So that is your short and long-term memory structure. All right. The next portion of the brain is the cerebellum. It's much smaller. It's about the size of a small orange or so. It sits beneath the occipital lobe, right at the base of the skull. It coordinates muscular activity for smooth, graceful movements. And if you want an idea of what the cerebellum does, think about toddlers and drunk people. For those two categories of people, the cerebellum is either underdeveloped or it's intoxicated, so it cannot work properly. And what you see is kind of a lumbering gait. Their movements are very uncoordinated, kind of sloppy. They may fall a lot, right? Toddlers kind of toddle around. That is what the cerebellum is ultimately trying to do, is kind of polish those movements, make them more coordinated. It's regulating the activity of your agonist and your antagonist muscles to make sure that they fire in a coordinated way. It's also responsible for things like your fine motor control, things like the ability to write with a pencil or type, sewing, cross-stitching, any kind of detail-oriented work that you may do with your fingers, video gaming, fellas. And it just gives you a sense of fine motor control. In the core portion of the brain, we have the diencephalon. This is where we talk about all of the glands in the brain, like the pituitary and the hypothalamus and your pineal gland. All of these guys sit deep in the core of the brain. And this serves as the primary relay center for all of the information coming into the brain. The thalamus is what ultimately acts like the switchboard operator, sending those nerve signals to whatever department they need to be relayed to. And last, we have the brain stem. So way down in the very basement of the brain, we have the most basic biological functions. When you look at the evolutionary history of the brain evolved from the bottom up and then outwards. So when you get to the newest part of the brain, which is the frontal lobe, that's where you get all the really sophisticated, really fancy stuff, like getting a personality and a sense of judgment and a sense of where you feel the societal pressure to behave a certain way, like not fart in public or whatever. Those kinds of impulses are regulated in the frontal lobe. By the time you get down to the core of the brain in the diencephalon, you're talking about higher level regulations like hormones and things like that, but it's still autonomic function, right? We're still talking about basic bodily functions. When we are at the level of the brainstem, we are talking about the very most basic rudimentary functions like heartbeat, breathing, body temperature, blood pressure, super, super basic. The brainstem is divided into three main sections: the midbrain, which connects it to the diencephalon above, the pons, which is kind of the relay station, and the medulla oblongata, which is the part of the brainstem that is the extension of the spinal cord. So the brain and spinal cord together comprise your central nervous system. The peripheral nervous system is everything else, all of the nerves. So these are your spinal nerves as well as the 12 pairs of cranial nerves. And I hope we remember our cranial nerves from AP3. Remember the names and the functions of all those cranial nerves? I hope so. I hope so. All right, guys. So that was a very down and dirty, very brief recap of the nervous system. The first major category that we are going to move into are traumas. So what all of these conditions will have in common is that they are all related to some kind of physical insult to the tissue. This could be, something as simple as a fall, maybe you got a little bruise, all the way up to something like a gunshot wound or a car accident. So the first one we will look at are traumatic brain injuries, or TBIs. TBIs, of course, are caused by physical trauma to the brain, but we're going to add a shade onto the definition here. If we're going to call it a traumatic brain injury, it has to be caused by some kind of physical trauma to the brain, not by some kind of birth defect or a degenerative illness, right? So the changes that would take place, like with Alzheimer's, for example, that's not a traumatic brain injury. With traumatic brain injuries, we're talking about something secondary to a skull fracture. We are talking about a penetrating injury. That is a very polite way. We're talking about a gunshot wound or a stabbing, something along those lines. The most common traumatic brain injury is a concussion. So a concussion is defined as like there was an impact to the brain, there was a loss of function, but there isn't any structural damage. So the physical connections of the brain are still intact. It got hit really hard and it just knocked everything offline for some period of time. A slightly more dangerous one is a contusion. Now, when you think about a contusion, guys, the easiest translation is a bruise, but you have to understand in sensitive tissue like the brain, bruising creates a lot of problems, right? Bruising creates the free flow of blood through the tissue, which means now brain tissue is not getting oxygen, right? All of the blood that's supposed to be carrying it, oxygen and nutrients, is now just leaking out onto the yard somewhere. So the other thing to be aware of is the brain is in a container. So when it gets damaged, right, the brain goes through the same process as every other tissue, right? The brain swells up, it becomes inflamed. But because the brain is in a hard, bony case, if the brain becomes inflamed, that can put pressure over a large part of the brain, and that pressure can squeeze off blood supply and it causes a lot of problems. So contusions are a little more severe, right? We've got bleeding on the surface of the brain. Another interesting one is a condition called coup counter coup. And if you've never heard of this one before, we see it a lot in forensics where we're trying to examine something that happened to the brain, usually through some kind of impact, but there's two sites of injury for that impact. The first is the initial injury, right? So someone gets hit in hit in the head, let's say with a baseball bat. So as the baseball bat impacts the head, the impact hits the brain suffers damage, and then because of the force, the brain gets pushed to the other side of the skull and impacts the opposite wall of the skull. And now there's a second site of damage where the brain bounced onto the other wall of its container. That is a coup counter coup. So you end up with brain injury on the impact side and the non-impact side. Another common one is termed diffuse axonal injury, meaning there's kind of a widespread injury to all of the axons, the nerve fibers, in some area. This is a classic case of whiplash. So, traumatic brain injuries. The primary takeaway for massage therapists is we have to understand we just listed a lot of different causes for a traumatic brain injury. So the complications that the person may be living with as a result of this injury will be as widely varied as the people who have them. We could be talking about minor losses of function due to a concussion. We could be talking about more severe loss of function due to repeated concussions. This is what's happening with all the NFL players, right? After years of playing football and all those concussions that they've received, functions of the brain, or the brain starts to lose certain functions. So they start to have mood swings, they get very irritable, they're not able to control their emotions. They may start engaging in more risk-taking behavior like gambling. There's a litany of side effects all the way to the more traumatic aspect where, sections of the brain, once they're destroyed, they don't heal, and we don't have the means to regenerate them. So we could be looking at various forms of paralysis. We could be looking at a persistent vegetative state. We could be looking at muscle atrophy. We, as massage therapists, there's very little that we would be able to do to treat the issue itself. Mainly what we would be doing is coordinating with the healthcare team, more specifically with their rehabilitation team, and employing those forms of massage that are supportive of that patient's rehabilitative goals. So the chief thing that we would be concerned with is making sure that we keep their muscles healthy. We're keeping their muscles, keeping fluid running through them. We'll keep them, gently stretched, maintain the integrity of those connective tissues, carry the limbs through a range of motion, make sure that those ligaments and tendons all get, a decent stretch put on them periodically. But what that client will be able to tolerate, what kind of pressure, what techniques will be recommended, it is so independent on the individual and what their exact injury really entailed. Good stuff. Nervous system disorders are always some of the more interesting ones. So please, guys, if you have any experience with one of these conditions, please feel free to speak up and share your experience. I have a few experiences with these that I'll share myself, but nervous system disorders are like my second favorite kind of disorder, second only to skeletal, of course. But you guys knew I was a bone guy, right?
I had a friend who had a AVM rupture in her head, I don't know, and she always refers to it as a traumatic brain injury, but it sounds like by our definition, that's not exactly right because it wasn't an outside force, it was something happening with her own brain.
Yeah. So if someone, let's say, just had like an aneurysm, that wouldn't meet the definition of a traumatic brain injury. It is certainly traumatic, and it is certainly an injury, and it does happen to the brain. So I understand where she's coming from, but generally with TBIs, you're looking at car accidents, you're looking at falls, you're looking at gunshot wounds, you're looking at someone got their ass beat. I mean, usually those are the kinds of things that we're seeing. With aneurysms and things like that, we would usually attribute those to the underlying pathology, like the aneurysm itself. Yeah. So everything that happened because of the aneurysm, like the resulting stroke and brain death and loss of function, the ultimate cause we would hold is the aneurysm.
Got it.
Good stuff. Good stuff. All right. Next up, we have a spinal cord injury. So the definition of the spinal cord injury, do I really have to go through this? This is going to be some kind of injury or damage to the spinal cord. So again, when we say damage to the spinal cord, we are talking about a range of injuries that could potentially happen to this tissue. And we can start with the best. I mean, if you have to have one, yes, the one you want a concussion. If you have to have some kind of impact, you want a concussion. The tissue is irritated, it's angry, it hurts, but it's not structurally damaged. It's sore from the impact, but it will recover, it will be fine. As we mentioned before, a contusion would be slightly more severe. This is where you now have bleeding somewhere within the spinal cord. So now the blood is leaking out, that's the bruise. This will damage the nerve tissue. You could lose some function. It could be temporary. When the bruise heals, you could get your function back. But if it's a severe bruise, you may not regain like full function from what you've lost. Maybe there's still some persistent muscle weakness or a lack of coordination or something along those lines. Now, a compression is basically that. It's some kind of mechanical pressure being put on the spinal cord. This could be caused by a slipped disc or a herniated disc. This could be caused by the growth of a bone spur. This could be caused by the growth of a tumor. Anywhere in the area, a tumor on the spinal cord, a tumor on the meninges, a tumor on the bone, a tumor on a muscle that's just happened to be in the neck, and that tumor is pushing on the spinal cord. But if there is one thing that we know about nerves, and you guys can sing along with me if you know the song, nerves do not like to be touched or poked or pressed or compressed or impinged or prodded or have any kind of pressure put on them in any way whatsoever. If you do, it hurts. And you get all the other nerve symptoms like numbness, aching, tingling, pins and needles, paresthesia. Anything that is going to put pressure on a nerve, it is going to cause the same kinds of symptoms. These nerve compression symptoms range from irritating, where like you can't snap your fingers because your fingers are numb, all the way to debilitating, where it's burning, radiating pain all the way down your arm, and you physically are too weak to lift anything with real weight behind it. Compression injuries can be annoying, or again, if it's a bone spur that's not just pushing into the tissue, but have you ever touched a bone spur? Those things feel like rougher than sandpaper. They grow out in these sharp, jagged protrusions. So if something like that is growing into the spinal cord, it's not just pushing, it's cutting and tearing and digging into the tissue every time you move, anytime the spinal cord shifts position. This has the potential to be incredibly painful, not just in the area, but because nerves wire up everything, that pain will radiate and spread all the way down the leg, potentially, all the way down the arm, potentially. Laceration injuries. Laceration is the medical term for cut. So with a laceration to the spinal cord, the cord has been partially cut. We would lose some function sometimes, again, depending on the severity. It may heal, you may regain some function. Then again, if it doesn't heal properly, or if there's too much scar tissue, or if the cut was really severe to the spinal cord, you may be looking at a permanent loss of function. Now, a laceration, again, is going to be defined as a partial cut, whereas a transection is a complete injury. A transection, the cord was severed completely. With a transection, necessarily, you will lose all function below the site of the injury. Everything above the injury will still work properly, but below the site of injury, all of those functions will become impaired. Again, these can be extremely complicated based on the exact nature of a particular person's injury. And I'll give you guys just a couple of different examples. Let's say, for example, okay, so there's my spinal cord. Let's say we end up with a laceration, something about like that. So you're looking at about a 50% tear in the spinal cord, but if the tissue is held together and we get medical intervention, again, we may restore some function. But let's say we end up with a unique injury to the spinal cord. Maybe there was a terrible car accident and the neck got not just torn, but twisted around. So the spinal cord had to suffer a torsion force, and then it tore along the line of tension. So the tearing kind of spirals around the spinal cord. You see this in spiral fractures on bones all the time. The tearing would look something like this, where we would end up retaining function for a slightly higher area on one side than on the other. So we would keep the function on one, I drew that on the wrong side, sorry. Sorry, give me a sec. There we go. We would keep more function on this side. So we would have function all the way to here, but we would lose function in a different area. So if that, let's say, for example, if that tear covered a couple of different spinal segments, like let's say C1 and C2, you would have function on one side of C1, but not the other. But you still wouldn't have function on C2. Another thing I want to talk about are the different kinds of paralysis. So spinal cord injuries will generally lead to paralysis of the affected area. And we generally recognize a few different kinds. We have hemi, we have para, and we have tetra. Also known as quadriplegia. So hemiplegia is paralysis of one half, like the left half or the right half. This is usually the result of a stroke. So the person loses function on one half of the body. With paraplegia, this is usually the result of a spinal cord injury somewhere in the thoracic or the lumbar region. So the person would lose function below the site of the injury, usually losing the use of their legs, but the neck and the shoulders and the arms may still be functional. And then with tetraplegia or quadriplegia, we have lost the use of all four limbs. This is the result of a higher level spinal cord injury, so somewhere in the cervical spine. But again, a spinal cord injury to the most proximal portion, like C1, C2 area, is usually pretty immediately fatal. So Usually people who survive spinal cord injuries are the ones where the injury occurred somewhere around C3 or below. So with spinal cord injury, one of the major considerations are the complications due to numbness. And I can just, complications due to numbness unpacks a lot of stuff, but generally what we're dealing with is either due to nerve damage or lack of circulation or whatever the reason, the nerves are less sensitive. So they are not as sensitive to pressure. So if you're really digging an elbow into them, they may not really feel it. So you may be going way too deep and damaging the tissue, and they simply have a blunted sensation, so they don't really feel it, and therefore they don't complain about it. And the next thing they know, they've got this like nasty bruise on their lower back, or you've bruised a kidney from like digging in around T12. We would also have issues where they may have difficulty differentiating hot from cold. So we would need to be very careful if we're applying heat to the body or if we're applying cold to the body. If you're using hot stones, for example, they may not be able to tell you that the stones are too hot. And second degree burns can happen much quicker than you think. And I will share a statistic with you. The number one reason why massage therapists are sued by their clients, number one reason, hot stone burns. True story. So when we say the side effect of this condition is the complications with numbness, that's kind of a placeholder phrase for all of the different kinds of things that we need to be aware of. If they're having numbness in their extremities, we want to be very careful with our pressure. We want to be very careful with our temperature. And if it's so numb that the tissue is kind of cold and they really can't feel anything, massage would probably be contraindicated for that area. Because if there's something impinging on the nerve function, they need to get a diagnosis and figure out what's going on. Massage isn't going to help if the nerve is starving of oxygen. Other massage considerations: people with traumatic brain injuries or spinal cord injuries, oftentimes there's a whole psychological dynamic that goes along with injuries of this type. It's very often that people like this are suddenly cast out of their friend group, right? Their friends don't come and call and hang out with them. They can't go out to bars and party or come to our kids' birthdays or anything. So they tend to just get stuck in a hospital somewhere and just left to convalesce, which can be maddening. So they start to experience very little touch from other people that isn't task related. So yeah, the nurse touched my arm when she had to change my IV, or someone like brushed my neck when they're like changing my pillow, but they don't get their hand held, they don't get hugs. And massage has very, very powerful effects on the body. When you're talking about someone who is psychologically isolated, just the aspect of human touch that massage brings to the table can be immensely therapeutic. Even if I can't really do anything for the condition itself, being able to offer someone compassionate touch and therapeutic touch during a time where they're most isolated and they're most vulnerable is definitely one of the better things about the massage field, for sure. And it's one of the things that we need to be aware of going into a situation with a client like this. Depending on the kind of injury, they may have difficulty communicating to you. So you'll need to be aware of subtle communication signals that they may be giving you about how comfortable they feel or how safe they feel. So you really need to tune in to your clients with conditions like this and really pay attention to their breathing, pay attention to muscle twitches, pay attention to if they're kind of shuffling around on the table, trying to like maybe reposition themselves. And just really pay attention to really be proactive in offering solutions to make them feel more comfortable while they're receiving massage. Of course, massage will help with the pain relief due to the muscle tension, and a lot of times muscle atrophy. If they're just laying in bed, not really doing anything, muscles will atrophy very quickly. The process will begin in just a few days. I mean, without moving, your muscles will start to basically digest themselves within 3 to 4 days. So atrophy will set in rather quickly. Manually moving the muscles, so like physically carrying the limbs through ranges of motion, compression type strokes, light effleurage, light petrissage, things that encourage fluid circulation, and then manually stretching and contracting the muscles will help kind of stave off some of the atrophy. And other than that, we just want to work with the team to help maintain whatever strength they have, maintain whatever dexterity they have. You know, when you've lost a lot of function, the name of the game is generally just going to be maintain, maintain, maintain. Good stuff. Questions?
Good stuff.
Yeah, I have a question.
Yeah.
Can you just quickly, if somebody has a transection, can you just quickly explain why the whole spinal cord wouldn't be affected and everything below the transection versus the entire, if that makes sense?
Yeah. So when you plug the cord into your phone and the power is going from the wall to the phone, if you snip the cable, that phone does not get any power. The wall could be working perfectly, right? Now, if you look at the cable instead, and let's say we just fray the lining so that some of the wire is exposed, that might still work. Even if you really get in there and start like messing with the wiring and cut some of those little copper cables so that we've now compromised how much wire there actually is, you will still get a signal, right? You'll still charge the phone. It may be slower than normal, right? It may not charge like it used to, but some function is still passing through the little frayed wire. But with a transection, when that spinal cord is severed, all of the cables are disconnected. There are no other ways of getting a signal below the level of injury to the spinal cord. If, let's say, if the issue was with a nerve, a peripheral nerve, then that might be a different story. With all of these different nerve pathways, we may be able to send a nerve signal through a different route using a different nerve and still end up in the same area, right? But we're not talking about a peripheral nerve. We're looking at the central connecting trunk, and the spinal cord is one of a kind, man. When it's severed, that's it. It's severed. The end. We hope that it's severed high enough that the person can still have some quality of life. But you know, I invite you guys to remember, oh Lord, what was his name? Christopher Reeves, the guy that played Superman back in the 80s. He was the Hollywood superstar, it man, and he got thrown off a horse and had a spinal cord injury. It was a compression injury at C2, I believe. And I mean, his head was there. He could still like talk and stuff, but he had like no function down below. And he spent the whole rest of his life raising funds for foundations for spinal cord injuries. But yeah, that's, in a nutshell, that's why a spinal cord injury is it's severe. And there's only one spinal cord. I hope good stuff. Okay. Sometimes I feel like my explanations get away from me. All right. The next category, or I'm sorry, the next condition we're going to look at is cerebral palsy. Now, cerebral palsy is an umbrella term. We are looking at several different injuries that could occur to the brain, and they all occur either during gestation or during birth or shortly into infancy. And again, these can be caused by a lot of different things, but collectively, what we're really looking at is, for some reason, the brain is generally the brain is being starved of oxygen. And so certain parts of the brain will begin to die as a result. Usually these are motor areas of the brain. So the functions that the person loses are things like motor control. So All right, let's start taking a look at a few of these. The first one we're going to talk about are the prenatal ones. So things that can happen to you in utero when you're still just a little baby in your mommy's tummy. If your mom contracts rubella, the inflammation from rubella can damage the child's brain, starving the brain of oxygen. Another more rare condition, to be honest with you, is called toxoplasmosis. This is the old cat lady disease, right? You get toxoplasmosis through cat litter boxes, and it like, I'm not super up to speed on like the details of this one, but it affects the brain. It causes like brain inflammation, and it makes you it makes you start acting super weird. This is why like there is the stereotype of the old crazy cat lady, because she has got so many cats and there's so many litter boxes, and she gets infected with toxoplasmosis. So then she becomes like more off her rocker. Hypothyroidism, diabetes, and RH sensitization is a rare complication with pregnancy. Generally, what you're looking at is a mother whose blood is RH negative. So you know your blood type, right? You're A positive or A negative. So if your blood type is a negative type and you get pregnant with a baby whose blood type is a positive type, and you have not been pregnant before with a positive type baby, sometimes the mother's immune system like just targets that baby for extinction and like goes all out against that negative RH factor blood. So if it gets sensitized and the mom's body starts launching an autoimmune attack against the fetus, that is a serious thing, and we need like lots and lots of doctors and medical people to deal with that situation. We need to get your immune system under control for the health of the baby, because your immune system does not give a single F. That baby is out of here if the immune system has its way. So now, some of the other types with the birth trauma. Now, these are events that happen during childbirth itself. These related to a lack of oxygen during birth. The two most common ways that this happens. Number one, the umbilical cord gets wrapped around the baby's neck in utero, and so the baby's being basically strangled. Another one happens, and I don't want to go off in too much of a tangent here, but I feel like it, you know what? I always run out of time. I'm going to go on a tangent. All right, sit down, buckle up. The way that Western medicine does childbirth in this country leaves a lot to be desired. First things first is we can have a whole debate about whether pregnancy is a medical condition or not. Personally, I'm in the camp that pregnancy is not a medical condition. That is a normal biological function. So like peeing isn't a medical condition. That's a function of your body. I kind of think the same thing about pregnancy. Now, just like with peeing, there's a lot of things that can go wrong. With babies, there's a lot of things that can go wrong. So you absolutely need doctors and hospitals and medicine and things like that. But when we start bringing women into the hospital when they're in labor, it's like we don't take into account anything that really benefits the mom. I mean, even just look at the position that they put you in. On your back, legs up, in stirrups. And then what do they tell you to do? Push. Anyone who's ever done natural childbirth will tell you the ideal position is going to be something resembling a squat. It's going to be like some kind of like hunched over squatting type thing where you are on your feet, allowing gravity to help you. So you're not having to push across gravity, right? Push him into like the waiting arms of some doctor ready to catch him. No, you should be underneath her so that when the baby drops, you catch the baby. Anyway, if you're not, delivering on the doctor's schedule, they will give you a shot of Pitocin. And then they give you an epidural, and that will numb you from the waist down so that now you don't have control over the muscles that you need to push. And then they'll tell you a C-section, and then they just do a C-section like it's no big deal. Like, oh, it's minor surgery. And a C-section is a big freaking major deal. You are cutting through like 17 layers of stuff to get to that baby. And now you have 17 layers of stuff that all has to heal back. We're talking about, guys, not just the skin. Remember, there's 4 abdominal muscles, 4 different abdominal muscles. Then all of your organs are in a sac called the peritoneum. And you got to cut through another organ called the greater omentum that sits out there. Yeah, if you didn't know about the greater omentum, check Wikipedia. There's a whole other organ that just drapes across your organs like an apron. You got to cut through that guy too. And then there's all this connective tissue that's in there, just like a spider webby stuff, just holding the organs in place so that your uterus doesn't like rotate around and stuff. Then you got to cut through the actual uterus itself, which is 3 layers of tissue, the middle layer being a super, super thick wall of smooth muscle. So yeah, C-sections are a really big deal. And you've just critically compromised the structural integrity of the core muscles. And I don't just mean like, oh, the really important ones. No, I mean like your actual physical core muscles. This is why after a C-section, you're not supposed to lift anything heavy. You're not supposed to bend over, right? They tell you get a bunch of bed rest. They're real quick to throw C-sections at people, right? And you'll even hear about especially in America, the women who schedule their childbirth. And they're like, no, I'm having a C-section on the 17th. I have a mani-pedi in the morning. Like, childbirth is a natural process. It happens when it happens, and it takes as long as it takes. Now, please take everything I just said with the appropriate grain of salt, seeing as how I am a homosexual male and pregnancy is totally theoretical to me. But I've watched The Business of Being Born, that Ricky Lake documentary all about childbirth, and if you haven't seen it, it is well worth your time. If you have seen it, you know what I'm talking about. It's ridiculous. The system is ridiculous. We should be funding doulas. We should be funding midwives. We should be funding home births and water births and all this other stuff. And like going to a hospital to have a baby should be reserved for the people who you absolutely need a doctor in the room for whatever reason.
That movie was amazing.
Thank you. It was so good. It opened my eyes. I'm a changed man. So complication number 1, going with cerebral palsy, is the umbilical cord gets wrapped around the neck of the baby, and so the baby is physically being strangled. Second deal is during the birth process, where the baby is in the birth canal, like actively being squeezed out, and something happens. Maybe the woman got a shot and it got her epidural and it paralyzed her from the waist down. So now her pelvic floor muscles cannot push the baby like they're supposed to be. Or maybe something went wrong. Maybe there is damage, or a million different things could happen. The point is the baby is in the birth canal on its way out and it gets stuck. And there's no air in there, right? Because this kid is like, you know what I mean, squeezed tight through this flesh tube, and there's no air. And not only is there no air, but the baby's lungs are full of amniotic fluid, so it doesn't even know how to breathe at this point. And the baby starts to suffocate. Now, let's say the baby comes out healthy, no problems, no issues, nothing. When you still are a little tiny infant, there are still bad things out there that can get you. If something goes wrong with the liver, and issues with the liver can produce jaundice as a side effect. Jaundice is a yellowing condition. We talked about this, right? We talked about jaundice.
Yep.
Okay. So we know what jaundice is. So if jaundice, especially when you're young, if it gets extreme, that amount of renin in the blood can damage your brain. It can cause deafness. It can lead to head trauma. You could also have other types of brain infections. So the brain itself could become infected with something like meningitis or encephalitis. So then the brain swells up inside its container, and that inflammation creates more pressure on the brain. Now you've got brain damage. or, you know, through something else like just anything that could lead to brain hemorrhage. If you're bleeding on the brain, a part of the brain will lose blood and therefore die, and therefore you lose function. So again, as with lots of these nervous system conditions, we're looking at kind of a spectrum of what kind of function may be lost. It's going to depend on how severe the damage to the brain was. It's going to depend on, you know, exactly what areas of the brain were affected. So if we're working with clients with cerebral palsy, communication may be difficult for them. So we want to be, again, very sensitive to nonverbal signals. Really tune in and pay attention to the kinds of signals that the body is giving you. They may also have the complications due to numbness. So we want to be careful with our pressure, be careful with stretching and overstretching, be careful if you're applying heat to the body or cold to the body. Because cerebral palsy is often accompanied by a lot of other secondary conditions, they may be on a lot of medications. So I would want to do a pretty thorough review of the medications that they're on, just to make sure that we're not creating any unintentional side effects or, you know, anything like that. And again, when I try to think of complications to pharmaceuticals, some kind of pain relieving drugs, like some of your heavy duty drugs are an intramuscular injection, where they inject the drug into the muscle and it's meant to sit there and slowly be absorbed over a period of time. If you come in and start doing massage over the area, you could increase the body's uptake of the drug. Number one, delivering them too much. And number two, the length of the dose doesn't last as long because so much of it got absorbed. Let me give another example. They may be on anti-seizure medication, right? Since the cerebral palsy can lead to muscle weakness or muscle tremors, they may be on certain kinds of seizure medication to prevent the tremors. Those kinds of medications can often lead to dizziness and nausea and things like that. So we just want to be aware they may need help getting on and off the table. Good stuff.
Good stuff. Is the cortisone shot something to be aware of, or is that not problematic?
I'm sorry, can you repeat that? I'm very sorry.
Oh, that's okay. Is a cortisone shot, is that something that is like one of the pain shots that you mentioned, or is that not like something that can?
I do think cortisone is one of the ones that they do, like they inject it. Now, the one that I was thinking of was a super specific example. For certain types of headaches, there's a drug called Amivig, and it comes in a refrigerated automatic syringe, but it's refrigerated. The drug is thick like syrup, and you just put the tube on your leg and you push the button, and it automatically like sticks out the needle, does the injection, and then it pulls the needle back, and you cannot touch the needle again. Right? It's like wrapped in rubber or whatever. But that thick syrupy medicine is injected in the quadricep muscle, and it's absorbed over a period of 3 days, and it lasts for a month. So if you do, you know, really good massage on that quadricep after the injection, it will be absorbed in less than 3 days, and the effective dosage won't last for a month. It will last for some amount of time shorter than that. And Amivig, again, is used for headaches, so it's pain relief. And if you're taking a monthly injection for headaches, please do not take a week away from my medication and give me a week of headaches. We'll just avoid the area. Brianna, I'm reading what you put in the chat, and yeah, it's intense, man. C-sections are, if I'll leave you with nothing else, I will leave you with this. C-sections are major surgery. It is not some outpatient procedure type deal. It is, C-sections are a very big deal, and you should not take it lightly. If you need one, get one. I'm not telling you not to get one. I'm just saying, I do not understand the moms who will just months out just say like, nope, I'm going to schedule a C-section on this day because I want it to be whatever. I don't get it. That's part of the magic of being pregnant, is like, it's a human experience. People just trying to ruin the magic, take the magic out of everything. Okay. So we've talked about what to avoid. What can massage therapists do for patients with cerebral palsy? We can alleviate pain and stress. We can increase muscular efficiency. We can aid with digestive function. If they're on pain meds, a lot of narcotics constipate you. So we could do like gentle abdominal massage to help encourage colon function, so we can help ease their constipation. And we can relieve muscle tension. Okay. The next category, right? We've looked at traumas. The next category we're going to look at are neurodegeneration disorders. So one of the things that these will all have in common is, number one, these will be progressive, meaning once they onset, they will gradually get worse over time. They are progressive, and they will lead to overall degeneration of the brain. Before we really get started though, number one, I do want to do a quick sweep of the room and see if anyone has any questions. Okay, number two, then let's take a break. Let's take 10, we'll come back and we'll get started with the next category. Good stuff?
Good stuff.
Awesome. Alrighty. Welcome back, everybody. Do I have everybody back?
I'm here.
I'm here.
I'm here.
All right. Okay, so the first one we're going to look at are peripheral neuropathies. So the name is telling you that it is some disease with the peripheral nerve. So this would be a cranial nerve or a spinal nerve. Usually peripheral neuropathies aren't the diagnosis themselves. Usually they're a sign or a symptom of some other condition. We generally identify either one nerve that's being affected, that's called a mononeuropathy, or it could affect multiple nerves or multiple branches from the same nerve. That would be a polyneuropathy. So peripheral nerves could be damaged through a variety of different things. Number one, they could just be getting a lack of circulation. That could be muscle tension, that could be tension from some other structure that's putting pressure on the nerve, like carpal tunnel, right? Carpal tunnel is the transverse carpal ligament running through the wrist. The ligament has become shortened, so it's putting pressure, it's narrowed the carpal tunnel, and that's putting pressure on the median nerve. So we start getting symptoms in the first 3 fingers and in the lateral side of the hand. We could also be looking at something like thoracic outlet syndrome. Thoracic outlet is the same kind of condition, except instead of a ligament pushing on the nerve in the wrist, you have a tight muscle that's compressing the brachial plexus in the shoulder. Usually this is going to be tension in your shoulder elevators, like upper traps, levator scapula, but this could also be in the scalenes between the anterior and middle scalene, or it could be a pec minor issue. Pec minor may be shortened. What else? Another thing that could affect a nerve is an infection. So nerve infections like herpes zoster or syphilis. Usually we don't think about syphilis too much. So let me give you just a brief little history lesson. Syphilis is sexually transmitted. It's a bacterial infection, and it's very contagious. When you first get infected, you will notice a painless red sore at the site of the infection. So like you said, usually it's sexually transmitted. So somewhere on your junk or near your junk, you get a little painless red sore. And it looks weird and it's concerning, but it goes away on its own after a week or so. And so we kind of like, whew, that was close, and we don't go see a doctor. A few months goes by, and then you move into secondary syphilis. You get a rash that spreads across the body. It's been a long time since that one sore you got a few weeks ago on your junk. So sometimes we don't really make the connection, right? Maybe I rolled in poison ivy, or maybe it was something else. So you give the rash a few days, and then the rash clears up on its own. For some period of time after that, the syphilis will begin migrating into the brain. And by the time you reach stage 3, tertiary syphilis, the bacteria is literally eating away. It's consuming like chunks of the brain. Not just the brain, it will spread out into the skull as well. And it will start to eat away at the bone tissue. So on the skulls of these people, you can see where the syphilis was eating away at the skull. It eats away at the face. It leaves these nasty sores all over you. It's horrifically disfiguring. Also, since it's eating away at brain tissue, you get to experience a very special kind of insanity called syphilitic insanity. Now, if you catch this infection way back at the beginning, when you just had that really annoying red spot on your junk, they give you a round of penicillin and it's cured. The end, go home, you're done, that's all. Nothing else to see here. By the time we get to tertiary syphilis, penicillin is not going to cut it. This bacteria is proliferating throughout your central nervous system. There's really very little that we can do at that point. So Fun stuff so far? Yeah.
Oh,
All right, so we've got herpes zoster, that's shingles. We've got syphilis. We've got diabetes. We've talked already about how diabetes affects the nerves through finagling with your blood sugar. Renal failure, if the kidneys are failing, that also throws off blood pressure and blood chemistry. Sarcoidosis, if you guys haven't heard of sarcoidosis, it's it's an odd disease. Sarcoidosis causes these masses. It's not quite a cyst, but it's not a tumor. They call them granulomas, or was it granul? I don't think they were called granulomas. What are they called? Something else. Anyway, it's not important. But it causes a proliferation of these small little cyst-like growths, and they develop all through your organs. So they end up in your lungs and in your liver and in your kidneys. And I shouldn't have to tell you guys, but when you have a growth in your lungs, that growth is not made of lung tissue. And when you have lung tissue that is not made of lung tissue, it can't lung. So when you've got these little sarcoid granuloma things in your lung, normal functioning lung tissue is being transformed into some other kind of tissue, which is usually bad. Same story in the liver or the kidneys, right? If your kidney tissue is suddenly overcome with all these little weird growths, then kidneys can't kidney and blood doesn't get filtered, toxins don't get removed. These cause all kinds of secondary disorders down the line as a result of those loss of functions. Second little minor, tiny little point. If you haven't heard of sarcoidosis, you should watch more House. He always thinks it's sarcoidosis or lupus, and it was never sarcoidosis and it was never lupus. So House man, he was a one-trick pony, man. What else can cause peripheral neuropathy? Chemotherapy. Yeah, taking drugs that are designed to specifically kill a very specific section of your body, generally not so easy on the immune system or on the nervous system. So chemotherapy is one. Alcoholism is another. Mercury poisoning, heavy metal poisonings affect the nerves. So again, there's just a whole list in varying stages of probability as to why this thing is happening. But peripheral neuropathies will be further classified, right? Whether mono or poly, we'll further classify them based on what kind of nerve is being affected. So remember, we'll have sensory nerves and motor nerves. So if sensory nerves are affected, then what you'll notice will be like changes in their sensation. So tingling, numbness, extreme sensitivity to touch. So even like a slight caress, it's a very intense sensation. Voluntary muscle control, you could, not voluntary, reduced sensation. Numbness can lead to secondary infections. So again, think about complications due to numbness. If there's an ulcer developing on the bottom of their foot and their foot is numb and they don't feel it, so they just keep walking around on this ulcer and it makes it worse. Bed sores, we could be talking about burns, potentially cuts, scrapes that they don't feel, so then they get infected. If motor nerves are affected, then generally what you see are issues with motor control, things like twitches, cramps, and if the muscle isn't getting a signal to contract, so they would think muscle weakness, but the muscle will start to atrophy. Again, days. This process only takes a few days before it gets started. And remember what we know already about muscles and how they work in groups, right? So it's very rarely just one muscle that's doing some action. Usually it's these groups of muscles working together to perform some action. So if one of these nerves, one of these motor nerves is damaged and only one of those muscles in the group isn't getting the signal to contract, then they may not realize that the muscle is atrophying. They just experience weakness when they move, right? But they're not attuned enough to say like, nope, that's brachialis, it sure is, right? They would not really notice the difference other than, you know, I tried to lift this thing and my arm's a little weaker than usual. We wouldn't see the atrophy until, you know, days into the process when the muscle had really started to atrophy, that we start to really experience a marked decrease in muscle strength. Now, we could, again, so we could have an infection of a sensory nerve. This could be a motor nerve, or more seriously, this could be an autonomic nerve. And remember, autonomic is automatic. So the autonomic nerves are the things that are connecting all of the automatic stuff that's supposed to be happening without my conscious input. So we could start having this infection or this condition. It could start to affect my digestion. This could start to affect things like heart rate or respiration rate. This could affect reflexes, things like swallowing. This could, I could lose control over sweating or blood pressure. You could lose control over bladder or bowel control. Or autonomic nerves, we start to get really nasty side effects when it's the automatic stuff that starts to fail. So for clients with peripheral neuropathy, what do we need to be concerned with? First and foremost, soothing touch, relieve the stress, improve local circulation, just overall improve quality of life. We can't address the peripheral neuropathy without addressing the underlying cause. So again, if it's an infection, they need to clear the infection. If it's diabetes, they need to get their blood sugar under control. Diet, medication, exercise, lifestyle change, whatever it has to be. If it's caused by some kind of temporary thing like an infection, then once the infection clears, usually the peripheral neuropathy will clear up as well. And peripheral nerves generally will bounce back. Generally, they'll heal, within a reasonable amount of time. They may be a little slow, but generally peripheral nerves will heal. If the peripheral neuropathy is caused by a more chronic condition or something that the client can't or won't fix, you're talking about something like, let's go back and think about renal failure. Well, your client can't just stop being in renal failure, right? Diabetes, you might be able to make some changes with diabetes, but generally speaking, when you have diabetes, you have diabetes. So with things like that, the peripheral neuropathy will follow them the length of their illness. Again, numbness affects their sensation, so they can't differentiate between levels of pressure, temperatures, just be cautious. Also be on the lookout for ulcers or some other kinds of skin damage, because you may be their first line of defense to spot something that's infected or a bed sore or an ulcer on their foot or something that may just, they just may not feel it. And you happen to look at the sole of their foot. It might be an uncomfortable conversation, you guys, but trust me, you can save a life. If that infection gets into the bloodstream, it can be nasty. There have been many times where I've had to point out suspicious looking moles or things like that to clients and say, like, you might want a dermatologist to check that out because, at the time we were living in Florida, and when you see a funny looking mole in Florida, it usually doesn't end well. So usually the most awkward part of the conversation is building yourself up to go have the conversation. Of the several times I've had to tell clients, I saw something suspicious, you should probably get it checked out. Most of the time they had already seen a professional and had been checked out and they had been cleared for it, or they had one of my clients had just gone to the dermatologist a few days ago and gotten it cleared. Like, it just happened. I had a few clients who had no idea that anything, like, what you saw, what? Yeah, I'll get an appointment made. And you never know, if you catch melanoma really early, you can totally survive it, but melanoma will flip and kill you fast if you don't catch it. So skin cancer is no joke, man, especially in Florida. That is no joke in Florida. Cool, good stuff, fun stuff. All right, next up, multiple sclerosis. Personally, I like multiple sclerosis as a condition. I mean, it's a terrible condition, don't misread me. But it's just a really interesting one to me. Generally, the underlying cause is autoimmune. And for whatever reason, we still don't know the mechanism as to why yet, but for whatever reason, your immune cells decide that Schwann cells are the enemy, and they go ham on trying to defeat the enemy. We will recall Schwann cells are the guys that are buddied up to the axons of your nerve fibers, and they're producing the myelin sheath, that fatty insulating material that makes sure that the nerve impulse stays contained within the nerve cell instead of being just diffused out into the tissues. So as the immune system targets the Schwann cells, obviously the Schwann cells are being destroyed and they cannot do their job. So the myelin will begin to break down, and it's not being replaced with myelin. It becomes replaced with scar tissue. And there is the rub. The scar tissue takes the place of the myelin, like growing on the surface of the nerve fiber. And scar tissue is not the same as myelin tissue. So it is not fatty and insulating. It is mostly collagen, and it's super tough. And so it starts to impair the ability of the nerve to send a signal along its axon. This results in the development of these clusters of scar tissue, which are called sclera, along multiple points on the nerve fiber. Hence the name of the condition, multiple sclerosis, a condition of having multiple sclera, multiple deposits of scar tissue. So now we know what the problem is. The problem is the scar tissue deposits. They are replacing the wrapping of the nerve. So nerve signals are no longer maintaining their integrity. In some cases, the nerve signals do not reach their destination at all. The cause of the scar tissue is the autoimmune attack. So what do? Well, we can give them drugs that modulate their immune response, right? So if you give them drugs and it dampens their immune system, then we cleared up that autoimmune attack. But now your side effect is you've just dampened your immune system. So now you're open to opportunistic infections like pneumonia or any kind of bacteria that's in, on, around your skin. So you've got to deal with all the side effects of that. Now, back to the topic at hand. As the scar tissue forms along the nerve, what we see with a pattern with this is periods of relapse and remission, or we say in the South, it comes in spells. So you'll have spells where the inflammation is getting severe. There's a lot of nerve pain. There's muscle side effects that go along with that. But after a flare-up, they'll usually go through a period of remission. Now, again, this is dependent on the individual. Some people will have relapses that last for weeks, and then they get months of no relapse. So this is something that just happens to them a few months every few years. Other times you'll have people who have hardly a few weeks in between prolonged relapses where they are under attack almost constantly. They get just a small breather where the inflammation subsides, and then maybe a week or two later, they have another relapse and they go back into it. So if you think about what kinds of things are going to happen when the nerves are under attack, numbness, weakness in the muscles because they're not getting a strong enough signal to contract, muscle tremors where they're getting like weird infrequent signals to contract, so they just kind of twitch around. Changes to vision. This happens for a lot of different reasons, either the nerves to the eye or the nerves to the muscles moving the eye. And remember, guys, with your eye, it's not just about moving the eyeball. You've got the muscles in the iris that dilate and constrict the pupil. So those muscles will also become impaired. So you get changes to vision. All the muscles in your throat can become affected. So you get slurred speech, and then nerve pain, because again, there's inflammation on the nerve and that's putting pressure on it, and nerves do not like to be touched. So for massage therapists, during a relapse event, massage is generally going to be contraindicated. Number one, it's contraindicated because they're undergoing an active immune response. There is inflammation in the body. Number two, because this is usually pretty painful and they're not going to want a massage. They usually won't seek massage during one of these events. There's a lot of muscle pain. There's a lot of nerve pain. It's just, they're super uncomfortable. They're kind of miserable. They're really not going to want a massage. Now, once that inflammation subsides and they go into one of the remission stages, massage is very much indicated. Thumbs up. Massage for this condition is indicated What we would aim to do is relieve the muscle stiffness, make sure we're stretching the muscles, particularly muscles that had been maybe held contracted or something like that. We want to do some gentle stretches, range of motion, circulatory massage, really focus on flushing out the old fluid and encouraging the intake of fresh, new fluid. But the cause is autoimmune, and there's nothing a massage therapist can do about that. We can just treat symptoms with the muscles as they arise. So be aware they will have the same complications of numbness. So just be aware that they may not be able to differentiate pressure or temperature. Also, since they're experiencing muscle weakness and tremors, they may need assistance getting on and off the table. Depending on what medicines they're on, I may want to do a medication review, but there is no medicine for multiple sclerosis. There are medicines to treat whatever symptoms they're having. So if they're not having muscle pain or they're not having muscle issues, then they may not be on painkillers or muscle relaxers. But then again, they might. So I would definitely want an updated medication list, just so I can spot anything that may interfere with massage or may necessitate a change in my treatment plan. All right, moving on to Parkinson's disease. All right, so little explanation here, but the core of the issue is with Parkinson's disease, the brain stopped producing dopamine. That's the cause right there. Dopamine is a neurotransmitter. It is involved in multiple systems within the brain. However, this specific disease is what the area that is being starved of dopamine is motor control centers. So you have healthy basal ganglia cells, and they are supplied with dopamine from a nearby structure called the substantia nigra. This is Latin for black stuff, literally the black substance, substantia nigra. What happens with Parkinson's is the cells in the substantia nigra begin to die. We do not know why, we just know that they die. When they die, they stop producing dopamine naturally. But when they stop producing dopamine, they are no longer supplying the dopamine to their neighbors in the basal ganglia. And those guys have to coordinate movements, and they need dopamine to do it. So if they do not have dopamine, they cannot coordinate muscle movement. So now think about what is the most visible and commonly known symptom of Parkinson's disease: tremors. And now we see why, right? So one of the defining features of this is a resting tremor. So when they are just at rest, the body trembles. Another one is bradykinesia. Now, I'll forgive you if you've never heard this word before. It's totally cool. Bradykinesia is it's a difficulty initiating movements. So even though, and again, it's hard to think about it when you're young and healthy and normal, but think for a moment. What would you do right now if your nose itched? You would just reach up and scratch your nose, right? But now think about that. You didn't really like say in your head, like, scratch your nose. You kind of just moved your arm and you didn't really think about it. With bradykinesia, when you kind of make that unconscious decision, like, oh, my nose itches, so you just move the arm, your brain registered that action potential. Your brain got the message. We need to send a signal to move the arm. But the arm didn't move. It may take a few seconds before the brain or before the arm kind of catches up and you finally move the arm. Things like this can make walking difficult. They can make sitting up and sitting down difficult, walking on stairs, things like this, because your brain sent the signal, right? You're thinking like, oh, I need to move something, but the thing just doesn't move on time. This can pose a lot of really interesting fall risks. This can create a lot of secondary injuries as a result of fall or slips and things like that. So that was bradykinesia. It's like a delay in initiating a muscle contraction. from the moment when you decide to actually contract the muscle. Cool, cool, cool. All right. Rigidity, muscle rigidity, the muscles kind of contract and they hold it and they just stay like contracted. Muscle rigidity. Poor postural reflexes. So if you just give them a little push on their shoulder, they might fall over. The basic normal reflexes that your legs and spine would do just to like catch your balance so you don't fall over, their brain's not working that fast with muscle commands, right? So they may fall over if you give them a little shove. Don't do that. That's not the official test for Parkinson's, guys. Don't do that. So shuffling gait, that's another one, a shuffling gait. So when they walk, they don't pick their feet up. They kind of like drag their feet again because it's difficult to initiate a muscle contraction, and also they can lose their balance and fall, so they tend to start shuffling their feet. Okay, so dopamine, super important in initiating motor control signals in the brain. But remember, dopamine is used all over the body. One of the places that uses it is the section of the brain that regulates your sleep-wake cycle. So without dopamine, their sleep cycle starts to get messed with. Anyone ever had to pull an all-nighter and then go into work the next day? Yeah, it's no fun. Having a sleep cycle disturbance like that, especially that's prolonged because of a lack of a neurotransmitter, you'll start to see dramatic cognitive functions, right? You're not your best when you're not well rested. Also, the frontal lobe uses a fair amount of dopamine. Remember, your frontal lobe is all about personality and will and judgments and all the really fancy human stuff. So they start to have personality changes. Dramatic mood swings are very common. What the term that I read was emotional diarrhea. They just, like a toddler, they lose their ability to hone and kind of control their emotions, and they just have tantrums and outbursts. Dopamine is also used to incorporate long-term memory, like into long-term memory. So without dopamine, they start to suffer memory loss.
Oh.
So please just be aware, a little side note, we did not list all of the symptoms. I picked a solid handful. There are many, many other effects that go along with a lack of dopamine, as well as the secondary kinds of disorders that this would cause. So when you ask about treatment, the natural, almost knee-jerk reflex would say, well, if the body isn't producing dopamine, can't we just inject them with dopamine? And the short answer is yes, but the longer answer is synthetic dopamine is expensive. I mean, we can make it for sure, but it's going to cost you. And like most drugs, the body will develop a tolerance. So it will require more and more of the synthetic drug. It's called L-DOPA, the drug. It's called L-DOPA. But as your body develops a tolerance to L-DOPA, so it takes more and more of the drug to get the same regulatory effect. And I don't know if I mentioned this before, but it's hella expensive. So, you know, how much dopamine can you afford? And there's our problem. So, massage considerations. Parkinson's patients will likely need assistance getting on and off the table. Their movements can become extremely uncoordinated and clumsy. Tremors make stabilizing themselves very difficult. The rigidity and the lack of reflexes can make standing up and sitting down difficult. So just be aware of their full health profile. I want to know as much about this person. I can do massage for sure. I just need to know that it's safe, and I need to make sure that my treatment plan has been altered accordingly to this person's medications and their physical abilities and whatever other contraindications may be presenting themselves. Massage can help improve sleep quality, right? By activating the parasympathetic system, we can hopefully start to kick them back onto a more natural circadian rhythm. We can help with the muscle rigidity through manual movement, trying to relieve tension in the muscle, light stretching, things like that. Massage also reduces the anxiety and the depression that accompany a degenerative condition like this one. So many massage therapists, according to research, have shown they get better results with Parkinson's patients when they do shorter, more frequent sessions. So think like 30 minutes, 2 or 3 times a week, instead of like a longer, less frequent session. So like your classical, like 1 hour a month. For Parkinson's people, we want to shorten those sessions and make them way more frequent, usually 2 to 3 a week, 15 to 30-minute sessions. All right. Next up, we have Alzheimer's. So Alzheimer's is a progressive degenerative disorder of the brain. Classic sign and symptom is going to be the memory loss. However, Alzheimer's can affect the entire frontal lobe. So there are also distinct personality changes, but this will eventually cause death. So the gist of what is going on is there's a naturally occurring protein in the brain called beta amyloids. And these proteins are sticky. They're used to hold structures together, but they're supposed to be cleaned out regularly and replaced. The issue is that they are not cleaned out like they're supposed to be for whatever reason. So they start to accumulate. So you start to get these accumulations of sticky proteins that will start to like stick to neurons and to other neurological structures. This triggers an inflammation response. So as the immune system comes in, everything becomes inflamed. We start destroying the plaque, but we also destroy the nearby healthy tissue. So those plaques are generally going to be found in the hippocampus, which is the memory center. Hippocampus is where your memories are stored, and throughout the cerebral cortex. So the cortex of the cerebrum, when you look at this little brain picture, it's the dark brown kind of line all the way around everything. So that's what you're noticing, is it's that outer layer that is really degenerated. So the outer layer is where your personality is and where your body control is. Hippocampus is where your memories are. So we start to see why degeneration in these areas are leading to the symptoms that we see with Alzheimer's. Another cause that generally happens concurrently occurs with another protein called tau proteins. Tau proteins are used for structural support of neurons, but what occurs is that they begin to degenerate and they start to twist and become tangled with other tau proteins. And these tanglings of proteins start to, number one, they start to pull and tug and tear down the structures that they're supposed to be supporting. Think about rafters, right? If the rafters caved in, then the roof would collapse because the roof now doesn't have a structure. So this is what we're talking about, right? Structural proteins start to degrade. So the structures that they're supporting start to fall and collapse. This can pull neurons apart from each other. So now those neurons can't fire together anymore. This could, lots of side effects. Anyway, back to it. As these guys start to become tangled together, these tangles get named neurofibrillary tangles. So neurofibrillary nerve fiber tangles. It's just the fibers amongst the nerve cells. Point of clarification here, though, with neurofibrillary tangles, the nerves themselves are not getting tangled. It's the support proteins among the neurons in the brain that are getting tangled, just to be clear. So as we tangle up these neurons and the structure starts to collapse and they start getting pulled apart from their neighbors so they can no longer fire together, when they're unable to send messages, the neurons will start to shrink and they will die. And there you see the results with severe Alzheimer's. You see that withering away of the brain as the actual structure of the brain starts to degenerate. Signs and symptoms include a loss of recent memory, poor judgment in decision making, increased difficulty in written and spoken language. So we just capsulized a lot of different symptoms there. We could be looking at things like they forget words or they use the wrong word for something. We could be looking at issues where they have trouble reading written writing, or they have trouble with their handwriting itself. We could be looking at an issue where they see a word and they see the word correctly, but they say the wrong word and they don't catch that they made the mistake. Eventually, as they lose more motor control, they will lose their ability to walk. They will lose the ability to communicate, to do any kind of self-care. And then ultimately what will probably kill them will be something like respiratory distress, where they lose control over their own breathing. Or, I mean, don't get me wrong, Alzheimer's itself will kill you just by itself, but there are a lot of other things waiting in line to kill you first. Respiratory distress, falls, things like that. So people with Alzheimer's are, again, likely to have a litany of other medical conditions that's kind of surrounding this condition. So whether that's other kind of brain degenerative disorders, or whether this is neuropathies, or they're going to have, you know, a laundry list of medications that they're on. Make sure that you are fully informed of their health profile. They may not be able to communicate verbally, so be super tuned in to their nonverbal signals for comfort and safety. But there is nothing that we can do to help the condition itself. Mainly what we're going to be responsible for is quality of life. Soothing, therapeutic touch that's not task-oriented. And you get better results with clients like this by making sincere, genuine human connections with them. But there's really, unfortunately, Alzheimer's is degenerative, and we don't have any way of treating it or reversing it or making it better. We're still researching it though, but all right. Next up, we have amyotrophic lateral sclerosis, or ALS, also known as Lou Gehrig's disease, because welcome to anatomy, everything has 5 different names. So here you see probably one of the most famous people with ALS pictured. It is Stephen Hawking. If you're uninitiated, Stephen Hawking is the one in the blue shirt sitting behind the computer. He's the one with ALS. This was taken on the set of Star Trek: The Next Generation in an episode back in the early 90s, where he starred as himself in an episode of Star Trek. Data thought it would be cool to play a poker game with some of science greatest minds. So he's playing a poker game in virtual reality with Einstein, Sir Isaac Newton, and Stephen Hawking. And it was a classic scene. If you have not seen it, you should totally watch it. It was so good. It was so good. So ALS, what is it? What is it all about? Well, basically, motor neurons in your spinal cord get destroyed and replaced with a different kind of cell called astrocytes. They're super important in the nervous system structural support, but they tend to be really fibrous. They're really good for structure and holding things together, but they're not so good for sending messages to each other. So most of these neurons that get replaced happen to be located on the lateral sides of the spine. And since the nerve gets replaced, then the nerve doesn't send a signal. And if the nerve doesn't send a signal, then the muscle never contracts. So the muscle atrophies. And here is where we get the name. Amyotropic, that is muscle atrophying, lateral sclerosis, a deposit of hardened material along the lateral sides of the spinal cord, leading to muscle atrophy. Amyotropic lateral sclerosis. Unfortunately, amyotropic lateral sclerosis is progressive, and it is eventually fatal. As we said, it generally affects the motor neurons. So your first few symptoms start to show up as things like difficulty with fine motor control. You may have difficulty holding a pencil and typing and, you know, intricate things like that. Eventually, this will progress into stumbling, loss of muscle control. Eventually, the muscles will atrophy and you will be ridden to a wheelchair. But remember, guys, the diaphragm is also a voluntary muscle. And so ultimately what will happen is as you lose motor control, you will lose motor control of like your diaphragm and the muscles for breathing. So you won't physically be able to breathe on your own, and that's usually in the end stage. One of the worst parts of this disease, in my opinion, but ALS, I feel, is probably one of the more sadistic diseases out there. And when I say sadistic, I mean, this is a disease that inflicts suffering just for the sake of suffering. Not only are you systematically watching your body betray you, and as you slowly lose control over, at first it starts with texting and typing, and then it progresses to it's harder and harder to walk, up until eventually you are riddled in a wheelchair and unable to move, till the end stage, I literally can't freaking breathe on my own. The thing is, this is an issue going on in the spinal cord. This is not an issue that's going on in the brain. So you're aware of what's happening to you. You are still in there. Memory is intact, skills are intact, knowledge, all of it. You are fully aware, painfully, excruciatingly aware of everything that is happening around you as your body slowly betrays you. Awful, awful disease, terrible. This is why I stuck that extra bullet point on this slide, just to point out there is no memory loss here. So effectively in end stage ALS, you will end up with what is effectively a locked-in syndrome. Are you guys familiar with locked-in?
No.
No, okay. All right, locked-in syndrome, known as a pseudocoma, is a condition in which a patient is aware. There is brain activity, they know what is going on. You are conscious inside your head, behind your eyeballs, but you cannot move, you cannot communicate verbally due to a complete paralysis of nearly all voluntary muscles, except for a few eye movements and blinking.
Ugh.
So you are conscious and you are cognitively intact, but you are only able to communicate through eye movements. When they do an EEG and check your brain activity looks normal.
Wow.
So they did an episode of House with a guy who was locked in. It was an interesting episode, but sadistic, man, just suffering just for the sake of suffering. Terrible way to go. So tripping, stumbling, progressive loss of motor control, eventual atrophy of muscles, extreme mood swings, no memory loss. So ALS patients will struggle with painful cramping. As the muscles atrophy, they contract very strongly. So design your massage in a way that minimizes strokes that may cause cramping. As they become more advanced, they will become more frail, and they will also become more vulnerable to secondary infection, so be cautious. You need to work with these patients as part of a coordinated member of their healthcare provider and a part of their healthcare team. These patients can find that special value in body work that's focusing on compassionate touch and relief of their pain, as well as strong breathing. Because if you want to try to keep a strong focus and really push the breath work and mindful breathing and things like that. But unfortunately, ALS only has one outcome. All right, good stuff.
Good stuff.
Good stuff. All right, how about another quick break? We're coming up on our next topic. So it gives us a nice little bookmark. We'll come back and we'll pick up where we left off, and we should be able to round out the evening. Any questions so far, you guys? I don't want to rush off if you guys have any questions at all. Okay, then let's take 10 minutes and I'll see you back here soon. right, we should have everyone back.
Yep.
Do I have everybody?
Cat's here.
See you, Kat.
I'm here.
Awesome. All right, cranial neuropathies. What we're looking at here are issues that will affect specific cranial nerves. So the first one we're going to look at is Bell's palsy. Notice what you're seeing here is the guy's trying to smile, but the right side of his face, it's not moving. Notice there's no wrinkles around the eye. The mouth seems somewhat relaxed, not really pulled tight. So Bell's palsy is an inflammation of the seventh cranial nerve, which is the facial nerve. This nerve provides mainly motor neurons, so movement for facial expression, blinking, things like that. Facial expression includes eyes and mouth, as well as a little bit of taste sensation. So oftentimes Bell's palsy will be secondary to some kind of infection. This could be a viral infection. If you have multiple sclerosis and your multiple sclerosis starts happening to this particular nerve, you could develop Bell's palsy. You could also be, you could also have Guillain-Barré syndrome. This could be another side effect of sarcoidosis, right? So Dr. House, no wonder why this name seems to pop up everywhere. No wonder he mentioned it all the time. So what we see with Bell's palsy is a flaccid paralysis of one side of the face. Often it appears overnight. You just wake up and one side of your face is just not working. This will present some interesting problems related to things like eating or drinking or blinking. But part of this also innervates the inner ear, and you may also develop hypersensitive hearing, which sounds awesome, but it's not awesome. It just, everything sounds really, really crazy loud. Like the ear is just super sensitive to sounds. So even relatively normal sounding sounds just bang on your eardrum. This is due to the paralysis of the muscles that are attached to your little ossicles, those little tiny ear bones. We may have mentioned this before, I may not have, but you guys remember from like muscles and kinesiology, remember the longest muscle of the body is sartorius, and the widest in the body is latissimus dorsi, and the most massive is gluteus maximus. The smallest muscle of the body, do we know, is the stapedius. The stapedius, which is attached to the stapes bone, which is the smallest bone in the body. The stapedius muscle is about 2 or 3 millimeters long. It is a really, really tiny little thing. So when those muscles get paralyzed, then they can't move the bones, the little inner ear bones like they're supposed to. That's why you get like hearing effects related to Bell's palsy. So Bell's palsy tends to kind of appear overnight, and if the infection subsides or the inflammation subsides, then the Bell's palsy will usually subside. But if the damage to the nerve is, or if the inflammation is prolonged, or the damage to the nerve is severe, or if the inflammation happens where the nerve is passing through a bony foramen, so that the nerve becomes inflamed inside its bony canal, and that puts a compression on the nerve, then you may end up with lasting effects from the Bell's palsy. So usually Bell's palsy will kind of clear up on its own with maybe a minimal loss of function, but occasionally Bell's palsy can be permanent. So if the underlying cause for the Bell's palsy, if that is contraindicated, we don't touch them, right? So if they have some kind of like active nerve infection going on, do not touch anyone who is infected with anything. If the underlying cause is, say, something like multiple sclerosis and they're in remission, they are not actively having a flare-up, then in that case, massage would be okay. So if the underlying cause is cleared for massage, they should be cleared for massage. Generally, what we're trying to do is just keep the facial muscles relaxed, keep fluid flowing, increase local circulation, and make sure that that tissue has good circulation, it stays strong, and we set the stage for a more complete recovery once the nerve has been restored, once the nerve has done its healing and is back to normal. We just want to keep the tissue in prime condition. Another condition involving a cranial nerve is trigeminal neuralgia. And this specifically affects the trigeminal nerve, which is cranial nerve number 5. And this is going to be neuralgia along the trigeminal root or in any of its 3 branches. It's the ophthalmic branch runs up to the eyes, the maxillary branch runs over the maxilla, and the mandibular branch runs over the mandible. You see how we named those. It's nice and convenient. Now, the trigeminal neuralgia has another name, a really cool name, which is French, which is unusual because usually these are like named after a person or they're named like in like Latin or Greek. But here we get a French one, and it's tic douloureux. Oh, that's so fancy. A tic douloureux. Say it with me. Tic douloureux. So it is a French word. It means an unhappy twitch. It's a painful spasm. This condition, this nerve pain and inflammation along the facial nerve, well, sorry, let me correct, not facial nerve. It's a nerve of the face, so it's a facial nerve, but it's not the facial nerve. The trigeminal nerve, it goes into painful spasm, and it causes muscle twitches on the face, and they're painful and they're unpleasant. So this condition could either be primary or secondary. Primary is, this is the problem, this is what it is. You have tic douloureux. This is usually going to be caused by a structural defect. Where the nerve is exiting the brain, there's a blood vessel that crosses right nearby. And some people just genetically, it just happens with the way that you're forming. The blood vessel forms around the nerve. And since it's in contact with the nerve and you like move your head around and stuff, the blood vessel starts to erode the myelin, and you end up with a little worn out spot on the nerve where the myelin is worn away and the nerve becomes exposed. That, again, think about everything we've just talked about with MS, right? With demyelinating nerves and what happens when you go demyelinating nerve fibers. With that little spot of myelin eroded away, now the nerve can misfire. So bad stuff, bad news. If your tic douloureux is secondary, and yes, I'm going to find every excuse I can to say tic douloureux as many times as possible tonight. Buckle up. If your tic douloureux is secondary, it will be secondary to some other problem like an injury to the nerve or a tumor that's growing and putting pressure on a nerve. Maybe there's a bone spur, maybe the nerve is infected, maybe you have MS, maybe it's a complication of surgery, maybe you got a facelift. If you're not familiar with how they do a facelift, they'll make an incision right along the hairline and they pull the skin up really tight, but they have to peel your face off to pull it back tight, right? So they like take your face off, like in Face Off. But when you go like taking people's faces off, you can damage the nerves that are just sitting right on top, like they're superficial to the muscle and all that other stuff. So if you damage the nerve getting a facelift, then boom, you have secondary tic douloureux, secondary to your facelift, you bougie French. So massage considerations. Massage considerations, any body work that might elicit symptoms. So if they're sensitive and you go poking around on their face, that's contraindicated, don't touch it. But usually we'll be able to talk with our clients and the client can kind of talk you through where they're sensitive or what hurts. And if you can take their feedback and provide a massage that is soothing to them and is not irritating to their condition, then massage is a-okay. You may not be able to perform prone work with them because, again, this nerve goes on the face and it's superficial. So laying in a face cradle for any amount of time may put pressure somewhere and it's not comfortable and they can't do it. So you may only be able to do face-up work. Massage can certainly address the muscle tension issues that arise from this. Also, they can kind of chronically guard themselves against these tics. So like the muscle tension that they just baseline will hold to try to stave off some of these tics can take its toll. They're keeping muscles contracted for a really long time, and the muscles will become ischemic over time. And facial muscles are just like every other kind of muscle, guys. You can hold tension in them and they become ischemic and they cut off their own blood supply. And now you've got a nasty condition where their cells are full of poop and they can't get rid of their stuff and they're starving for oxygen. And massage can help with all of that. Not much we can do for the nerve itself, though. Everybody good with tic douloureux? Had to get one more in. All right, other neurological conditions. These things are just kind of, we're just gonna lump them all together. Headaches. Bro, probably one of the most common human experiences, right? We're all born, we all pay taxes, we all have headaches, and then at some point we die. Like, welcome to life on this rock. But headache, oh, that is a loaded word, man. The headache covers any number of painful, debilitating neurological conditions. And there's no real good way to classify headaches, because with so many different headaches, structurally, there's nothing wrong. And what I mean is, I don't mean that the headache does not exist. What I mean is, when we try to image the brain, when we try to map the blood vessels or map nerve firings or look at brainwave patterns or any of these things that we try to see what's going on, we can register that the person is in pain and under stress, but we can't identify any kind of actual structural defect that would account for what the person experiences. So we have to rely on people's self-reported pain experiences. And again, pain is really personal. The perception of pain is modulated by a lot of different factors. People's prior experience with pain, right? What kinds of painful things have you experienced in your life? When you think about like 2-year-olds and they stumble and they skin their knee and they cry and they cry and they cry, because in their whole 2 years of life, that is the most painful thing that they have ever experienced. And you or I would shrug off a skinned knee for just what it is. Like, it's no big deal. But you got to remember, being the most painful thing they've ever experienced, their rating of that pain would be rather high, you would imagine. Now, if you were to take, let's say, maybe like a Navy SEAL, someone who's been trained to withstand torture and who regularly puts their body through grueling acts of physical endurance, well, you would imagine that another experience that someone would rate as incredibly painful, like breaking a bone, one of these really tough Navy SEAL guys could probably get a lot done with a broken arm, where for sure, I would be on the ground. I'm a baby when it comes to pain. I cannot take pain. Think about childbirth. Think about kidney stones. Anyone ever experienced a lumbar puncture? Yeah, anyone ever had to get a spinal tap before? Anyone had to be catheterized?
Yeah.
Anyone ever had to be put on a ventilator?
Whoa.
These things are not pleasant. They are painful. And in a lot of cases, they are traumatic.
Yeah.
So when we talk about pain, pain is a nebulous word. It means different things for different people. So what we try to do is we try to, as best we can, kind of make it uniform the way we talk about pain. And if we can kind of agree to talk about pain in the same kinds of ways, then we can more intelligently discuss conditions and issues and symptoms and prognoses. So generally what we would do is rate pain on the scale of 1 to 10 or on a scale of 1 to 5, whichever one you prefer. But 1 to 10 gives people a little more range. And you've seen that in every clinic you've ever been in, right? With the smiley faces from like happy to sad, or, you know, I saw a really funny one where you get to number 6 and it's like bees, and then you get to number 7, it's like bees. I thought it was funny. So we also try to kind of standardize the words that we use to describe the pain. So oftentimes when you ask someone like, what kind of pain is it? You'll hear words like it's an aching or a throbbing, or it's a burning or a stinging, sometimes a painful pins and needles, like you feels like you're being poked with lots of different needles over and over. That may transition to a more blunted pins and needles where it just feels like static, right? Like someone changed the channel on your arm and now you're just all, to out and out just numbness where like they feel nothing. There is no sensation at all. They can move it, but they can touch something hot, they can touch something cold, it doesn't work. We try to standardize these vocabulary around pain so that we can all again have a common language as to how we talk about it, because pain is so personal and it's so colored and flavored by your previous experiences with enduring pain and different kinds of pain. You know, you may be a manual laborer and you're used to the muscle burn of, you know, exerting your muscles and overdoing it, but one good bout of sciatica with a nerve pain shooting down your leg, and this 6'5" burly man will fall to his knees. Or, or you really want to bring the king down to the level of a commoner? Give him a kidney stone. Nothing quite humbles you like the exquisite pain of a fucking crystal tearing through your ureter for days and days. So this is just my little preface so that when we get into headaches, we kind of classify them kind of just where the headache happens and kind of how the headache comes about. So tension headaches generally occur when the person is under a lot of stress. They are often related to muscle tension, and these kinds massage therapy is very positively indicated for. Tension in the posterior neck muscles, tension in the suboccipitals, tension in the occipitofrontalis muscle, the temporalis muscles. You freaks who are stressed all the time, you live in Portland. What is there to be stressed about? But we clench our jaws and we hold all of these submandibular muscles and we keep our SCMs engaged, or we keep our head pointed down at our phone as we just doom scroll the news day after day. All of this tension starts to pull, not just on the bones, you guys. Remember, it's not just about the bone. When the tendon connects to the bone, the tendon spreads out and becomes the periosteum of the bone. So that when the muscle pulls, it's not just pulling on that one little spot, it's pulling on the entire covering of the bone. So when you have 8 cranial bones and 14 facial bones that are all articulating perfectly together to form this precise case around the brain, if there's tension really pulling on one of those cranial bones, then the bone can be pulled out of place. And then underneath the meninges, they're anchored in there. Like they're attached to the inside of the skull as well. And the meninges surround the brain and spinal cord like a skin tight sweater. So if the meninges are being pulled up here, you'll notice tension down here, right? Think about it. If you're wearing a sweater and you get your pocket caught on a doorknob, right? When the sweater gets pulled, you don't feel that. You feel the tension up here, right? In a different place from where the action is occurring. So the same kind of thing happens. The whole craniosacral system, it's an integrated, it's a one solid connected system. And if you pull a little piece out, it creates problems in the whole system. that's where craniosacral massage comes in. That's that whole division of massage, craniosacral. So tension headaches, muscle tension. Migraines. Migraines last for days at a time. They typically affect one side over the other, although there are certainly people who have migraines that light up both sides of their head. These are the ones where the headache is so intense, they are super light sensitive, they are super sound sensitive. Smells will make them nauseous. The pain is intense enough that they're nauseous already. And the way you treat it is you got to figure out what works for you. For some people, they just need some time to recoup. For some people, they need to be injected with an anti-nausea medicine, and they need to be injected with a painkiller, and they need to be locked in a dark room and left to sleep for 3 days, and they'll wake up right as rain. Cluster headaches are where the pain is kind of clustered in general areas, or rebound headaches are headaches that occur after some other kind of illness, like a headache after vomiting, right? Or you had an infection, and then after the infection, you get a headache. Secondary headaches are secondary to some other condition, and they're indicative of the kind of condition that is causing them. Better examples would be something like encephalitis or meningitis, where there's an infection of the brain, and so the brain swells, and as the brain swells, it puts pressure on the skull, and bibbidi bobbidi boo, you have a headache. Now, with those kinds of things, again, the headache is secondary to the infection. Stroke, aneurysm, both of these conditions will onset with an intense headache. Are you raising your hand, Zebedee? Zebedee, are you raising your hand? Do you have a question? Okay, just checking.
No, sorry, I'm just stretching.
That's okay, that's okay. All right, so again, generally with the more debilitating kinds of headaches, like cluster headaches and migraines, they are not going to come to you for massage. They want to be locked in a basement somewhere. They do not want to go anywhere. Their head is absolutely killing them. With tension headaches, massage can be indicated, but if they actively have the headache, you may want to I would probably wait, because putting pressure on the muscle that's actively angry is probably not going to do much good. It's probably just going to make the condition worse. You want to give it some time, ice, NSAIDs, maybe just some Tylenol or something like that to try to take the edge off. Let them get over the headache and then focus on the muscle tension would be my recommendation. Now, if the headache is accompanied by a fever, fever is a sign number one for an infection. And if they are infected, you do not touch them. Infections are contagious. So if they've got a headache and a fever, reschedule. If they have a headache coupled with like confusion or numbness or some other kind of like nervous system type of thing, massage is contraindicated. This is probably a medical emergency. If they've got a headache and some other neurological issue like numbness or tingling or the confusion, don't waste your time trying to diagnose what's wrong with them. Just get them to a doctor. So tension headaches, again, good for massage. We focus on the musculoskeletal stresses. We would focus on the stress-related muscle tension patterns, the holding patterns, the clenching of the jaw or the tension in the neck. And those patterns will contribute to inefficient movement over time. So trying to preserve their range of motion, their ergonomics, their body mechanics. That's where we fall in here. Okay. Seizure disorders. Seizures are quite complicated. So again, there are many, many different categories of seizures, and having different types of seizures can qualify you for different types of epilepsies. Generally, epilepsy is diagnosed when you undergo 2 or more seizures within a 24-hour period. And by seizure, they have to be like basically a generalized seizure. So the issue with seizure disorders, right, when all of the neurons in the brain get stimulated in a particular way, they release a nerve impulse. They release a small burst of electricity. This is how neurons work normally. What happens with seizure disorders is that huge groups of neurons all generate a very high frequency burst all at once. Remember, they cannot modulate the strength of the nerve impulse. They can only modulate the frequency of a nerve impulse. So when this huge group of neurons all release like these enormous action potentials all at once, the electrical system of the brain just goes haywire, and the system has to like shut down and reboot. You ever left your cell phone on the dashboard and your iPhone tells you like high temperature? It won't like do anything until the temperature comes down. Yeah, it's kind of something along those lines where there's just so much electrical activity in the brain that it disrupts the normal function. The reaction will get repeated because that signal gets sent to the next neuron. So once this batch of neurons releases the action potential, that action potential reverberates through the brain, through all the networks and intricate connections of the neurons. This is like a lightning storm in the central nervous system. So most basic, we can categorize seizures into general or partial. But again, each of these is going to break down into their own subtypes. And even the ones I've listed here are just a picking of the full list of these real conditions. So the easiest one to explain is an absence seizure, which is so aptly named. I freaking love it. You basically just lose consciousness. You just kind of check out for a few seconds and you have no memory that you checked out. So you just mentally, there's just a gap that you're not aware of, just for a few seconds. There's usually no muscle activity or anything like involved in this. You just consciously, you just blank out for 10 seconds. Now, we're not talking about like a normal, like, oh, I was thinking about like my high school history teacher. Like you had an actual like blackout moment where people are like, what just happened to you? Are you okay? And you don't remember what just happened to you. That's what we're talking about. Clonic, jerking movements, either in the upper limbs or the lower limbs, with or without loss of consciousness. I abbreviated that LOC just because it's a bitch to type out over and over. Sorry. So jerking movements with or without loss of consciousness. Tonic is different from clonic. Tonics is they just contract and hold. Usually this results in flexion. Flexor muscles, just side note reason why, not super relevant or important, but generally speaking, your flexor muscles tend to be the ones that are more used. Therefore, they tend to be the ones that are stronger. So when your muscles contract, if it's between a flexor or an extensor, the flexor is generally going to be stronger. And just think about it. How many times do you lift and how many times do you actively have to use the tricep to push behind you, right? You see what I'm going with? So that's why. Anyway, not important. Tonic seizures. The muscles tighten and hold. This usually results in flexion. This can last for seconds to minutes at a time. Tonic-clonic seizures are also called grand mal seizures, and these are the big guys. These are very serious. These are the ones where you lose consciousness, you are thrown onto the floor, you have no control over your muscles. And when you think about a seizure in the movies where someone is like having fits all over, that is a grand mal seizure. That's what they're trying to convey to you, is that they're having a tonic-clonic seizure. The next one is atonic, or a without tone seizure. This one causes a complete loss of muscle tone. So instead of the muscles contracting or being uncoordinated, every muscle in your body just lets go and you just collapse. The risk here is falls, and that you may fall downstairs or fall off a ledge or off a cliff or whatever happens. But the risk here is the injury of a fall. So partial seizures, we have simple and complex partial seizures. simple partial seizures do not involve a loss of consciousness. Usually it's just kind of like a consciousness thing where you have like a mild seizure, but your body doesn't convulse. It's more of like a mental thing. Your sensations get really distorted. You may lose your balance, get some vertigo. You may have a little tick or twitch kind of thing, but it's usually kind of brief and transient. On the other hand, complex partial seizures are known to occur, and this is specifically associated with temporal lobe epilepsy. And what time is it? 8:30? It's 8:30. I think I have a little bit of time. So temporal lobe epilepsy is a very interesting flavor of epilepsy. Normally, when you think about epilepsy, you just think about seizures where the person is just thrown on the floor in convulsions. They usually don't have memory of what happened. They just kind of come to later on. And that's the more well-known, but temporal lobe epilepsy has distinctively different symptoms. The temporal lobe is responsible, as we said, memory, speech, things like that. And I am not a neuroscientist. I cannot explain why this is. You will need to ask someone way smarter than me why this is. I can just tell you what it is. The temporal lobe epilepsy causes, instead of like seizures, it causes like hallucinations. And the hallucinations, a lot of them fall under the same categories. They are profound religious experiences and alien abductions. And when we, in the laboratory, stimulate the temporal lobes of people, we can induce them to have temporal lobe epileptic hallucinations. And a lot of them have religious experiences, or they have something related to being abducted by aliens. And I cannot explain it. I'm just telling you, it is really freaking weird.
You guys, my friend, my coworker today just told me that he's like going to the neurologist to be tested for this because he's having like crazy things happen. And the neurologist is like, yeah, we think it's this, but like we don't know. You have to get a EEG scan, find out.
What kind of stuff is he experiencing? He said weird stuff.
Yeah, I mean, like he was talking about how like he'll just like kind of like black out for a second and then like come back with like this entire story, like, and he's like, okay, it was just 15 seconds, but like literally I just downloaded like an entire story about like squirrels like entering the store we work in, and like it's like really like creative and mysterious and weird. Like I don't know if he has like alien abduction stuff happen, but like honestly I wouldn't be surprised.
Well, and again, please don't misunderstand. I'm not saying all of them. I'm just saying like with these kinds of hallucinations, there's an inordinate number of these two flavors of hallucination. That's all I'm trying to say. But it's really fascinating. I mean,
Indication of aliens for sure. I mean,
right? I mean, I would hope if I'm gonna have some hallucination disorder, I would hope for aliens.
Yeah.
I would expect nothing less. All right, so massage considerations for seizure disorders. If they are actively having a seizure, please call 911. They do not need a massage when they are actively having a seizure. Good stuff. When they are not having a seizure, however, try to minimize the triggers. So if they know what their triggers are, ask them, communicate with them, but be prepared to adjust the lighting or the ceiling fan, or be careful with scents, right? Certain kinds of aromas or music. I mean, just ask lots of questions. Make sure that they know everything in this room is customizable. Even I am customizable. If I'm doing something that's triggering your seizures, or the fan can be on or off, whatever. It's all customizable. Use care with anti-seizure medicines. A lot of times these will cause fatigue or dizziness. So they may need some assistance getting off the table. They may be a little, they may have a little massage brain going on when they get off the table. But other than that, focus on muscle tension, things like that. But seizures shouldn't present a problem as long as they're not actively having a seizure.
As massage at all been known to trigger anyone's seizures while they're getting a massage?
Not that I'm aware of, no. Not that I'm aware of, no.
Just curious.
All right. Last one, guys. This is the last one. Meningitis. All right. Meningitis. The name right there. Inflammation of the meninges. That's what's going on. The question is, why is this going on? Meningitis is caused by an infection. The question is going to be whether the infection is viral or bacterial, but it's caused by an infection, which means it is crazy contagious. So rule number one, do not touch meningitis. Do not let them in your spa. Do not shake hands with them. Do not give them a hug goodbye. They need to go to the hospital and wash their hands on the way, and don't touch my doorknob. Crazy, crazy contagious. The infection triggers inflammation of the meninges, usually the pia mater and the arachnoid mater, which are the more delicate, deeper layers beneath the dura mater, the really protective one. If it's a viral infection, your more common suspects are herpes simplex or herpes zoster. Herpes zoster is shingles or HIV. If it is a bacterial infection, your most common culprits are going to be tuberculosis or TB or the consumption or staphylococcus. You got staph in your head. That's fun. So, side effects of an infection. Number one, fever, shocker. And then chills. Does that say chills? That says high fever and chills. It's supposed to be high fever and chills. Sorry. You will also see a manifesting of a red or purple rash. That's what I've pictured here. It's just like a little pinprick rash. And it doesn't tend to be super profuse. It's not like all over the body. It tends to be just in one or two areas. Aversion to light and irritability, headache, extreme headache because the brain is swelling. But here is the telltale sign, you guys. Here is like what it boils down to. Headache, fever, stiff neck. Headache, fever, stiff neck. Remember, it's an infection of the meninges, and the meninges are not just on the brain. They're on the brain and spinal cord too. It's one continuous sac. So when this sheath is inflamed, bending the neck, right, and bending the spinal cord puts pressure on the sac, and it's very stiff and it's painful. So a headache and a fever and you have a stiff neck, those are grounds to go to the emergency room. Like insurance or no, you need an emergency room. Meningitis can be extremely contagious. It will shut down your spa. You do not want it. Meningitis breakouts will shut down college dorms. They will send all them kids home for the semester while they disinfect everything. It is not a joke. It is bad stuff. So, systemically contraindicated. Do not touch them. Do not let them in your spa. They need to go to the emergency room. Questions? What do we think, guys?
Midterm after this, right?
Correct. And midterm opens today after class, and it closes when class starts next week. And do not be taking the test when class starts because it auto submits whatever you've done. So get it done before class.
Sounds good.
Cool. Any questions about this stuff? Okay. Well, then I have some questions. Which disorder was brought about by shortages of dopamine to supply the basal ganglia in the brain, and the result was a loss of muscle coordination and balance and increased rigidity?
Parkinson's?
Parkinson's. Good job. Your client tells you he has a seizure disorder. During the massage, he has a seizure. Give me 3 massage considerations.
Call 911.
Call 911 for sure.
Turn off the lights. Well, Yeah.
Hmm.
Stop the massage.
Helping him off
What
the
else?
table.
May want to help them off the table, yeah. Or you may want to physically, you may have to physically keep them on the table.
Yeah.
Like when they're seizing, they may fall off the table. You really have to try to keep them on the table.
Yeah.
Can't stress that enough. Can we think of anything else?
Mm,
Holding their tongue a myth, right? Because they're not gonna like. That's not
Yeah.
gonna happen.
I'm not putting my hand in anyone's mouth. Like, you can't pay me for that. I did not go to dentist school. No. Sorry, that's just me. I'm not putting my hand in anyone's mouth. All right. Give me 2 causes of peripheral neuropathy.
Diabetes.
Diabetes could be one, yeah. What else could cause peripheral neuropathy?
Alcoholism.
Alcoholism,
Thoracic outlet syndrome.
thoracic outlet syndrome. So with thoracic outlet syndrome, also any other compression syndrome like thoracic outlet or carpal tunnel or sciatica, or like piriformis syndrome, sciatica. What else? Can we think of any others?
Syphilis.
Syphilis, good.
Exposure to toxins.
Yes, heavy metal poisoning. One of the more common is mercury. One of the more common is mercury poisoning. All right, your client has Bell's palsy. Which of these should you do?
C.
Does everyone else agree?
B.
What was that? B?
yeah.
B
B,
like
B as in boy.
avoid work on the head altogether.
So this question, certainly I would say it depends on the cause of the Bell's palsy. Because again, if it's an infection, you don't want to touch them. But if it's MS, then, it's fine. But I think the best answer for what we have here is the avoiding work on the head altogether. So one of the objectives with massage for Bell's palsy is that we want to keep the tissue in good condition, anticipating the restoration of the nerve. I think the best answer is C. I think Eric got this one. Perform massage, but avoid work or very lightly on the affected side of the face. I think that would be. Because again, there are so many nuances with neurological disorders that we can all envision a scenario where each one of these answers is the correct one. I mean, if the peripheral neuropathy is caused by a shingles infection and she actively has shingles, then D is the correct answer. If she has shingles, she's contraindicated. You don't touch her.
Yeah.
But if it's if it's caused by MS, I would say go for it. Just be careful. Communicate with the client. Make sure you're doing, something that's soothing to them. So it's an interesting one. How about massage as part of a healthcare team is usually appropriate for a person with ALS? Why?
I'm gonna
B?
say B.
Anybody else want to say B?
B.
I agree with you guys. ALS affects motor neurons rather than sensory neurons, so they can still feel your touch. They can still appreciate massage. A person demonstrates the following signs. They have asymmetrical dilation of the pupils, so one is dilated and the other is not. Sudden blinding headache, difficulties with speech, weakness on one side. Which of these is probably happening?
C again?
A.
Got a variety of guesses here. So let's think about this.
I was almost thinking A too, yeah.
So, sudden blinding headache. That tells you the problem's going to be somewhere in the head. Headache isn't usually a symptom of a heart attack. Now, sudden headache, that's extreme encephalitis. I can probably rule out head injury. Asymmetrical dilation of pupils, that tells you there's a neurological function that's been lost. So dilating the pupils and keeping the pupils dilating together, that's there's been some brain damage somehow. Weakness on one side, that tells you also something's happened to the brain because one side of the brain controls the other side of the body. This sounds like a stroke, fellas.
That's what I thought too. I was like, which one's a stroke?
A cerebrovascular accident. That is a stroke, a cerebrovascular accident. Or a CVA. You'll hear strokes called CVA. Which condition? We have degeneration of synapses in the brain because of buildup of plaques and neurofibrillary tangles, leading to a loss of memory and cognitive function, and eventually to death.
Alzheimer's disease?
Alzheimer's disease. Very good. Which region of the brain is responsible for auditory processing, speech, expression, and memory?
Is it the frontal?
Amelia?
Temporal lobe.
Temporal lobe. Auditory processing, hearing, the temporal lobe is like an earmuff. It's right there. So when you think about temporal lobe, it's hearing and also memory. The collective term for several injuries to the brain during gestation or infancy, leading to cognitive impairment and disruption of physical or behavioral function. Traumatic brain injury, peripheral neuropathy,
Cerebral palsy?
cerebral palsy. Jesus Christ, I blanked on it. I'm so sorry. Cerebral palsy or spinal cord injury. A collective term for several injuries to the brain during gestation or infancy, leading to
Cerebral
cognitive
palsy.
impairment.
Cerebral palsy.
Cerebral palsy for the win. Tension headaches, migraines, cluster headaches, and rebound headaches are all forms of, if you say headache, I'm going to scream.
It's primary, right?
Oh, you're a gem. Primary headaches. Very good. Primary headaches. The inflammation of cranial nerve number 5 is called
Trigeminal neuralgia?
trigeminal neuralgia. So inflammation on cranial nerve 7 is called? For 300, Alex. Bell's palsy.
Tic de la Roe?
No, Bell's palsy. Tic de la Roe is trigeminal neuralgia. Ooh. All right, name 2 massage considerations when working with a client with multiple sclerosis.
Make sure it's not flaring.
Very good. Make sure they're in remission. Light touch. Zebedee. Yep. All right, so we've got degeneration in a nerve, which can lead to numbness and tingling and muscle weakness. So if they have numbness, what do we need to be aware of?
They have a loss of sensation, so we don't want to go too deep.
And be careful with
Temperature.
temperature. Very good. Loss of sensation, so be careful with pressure and be careful with temperature. What is coup counter coup? Amelia's got it. I can't hear a word, but I see you over there. Yeah. Impact to the head causes the brain to impact the opposite side of the cranium, suffering a new injury to the brain. So there's double injury.
Now, was that the same or different than whiplash?
That is different than
Okay.
whiplash. Whiplash happens to the axons in the spinal cord and in the nerves, whereas coup counter coup is the brain injury from the brain rattling around the skull.
Okay.
Yeah. And again, guys, I just want to say, when I explained coup counter coup, I made a very clean, like, bam, bam type of illustration. Just understand with the more violent impacts, it goes back and forth several times. So there are multiple impacts as the brain like literally jiggles against the walls, like forcefully impacting the walls of the cranium. And the brain is super squishy and like really super duper fragile. It is not like a firm, substantial organ like a heart. It's like you could stick your finger in it and your finger would just like pudding, your finger would just smush through it. And you could just take a scoop with your finger and like mayonnaise, you could just scoop your finger through it and just destroy the brain. It really is super, super fragile. Really, really fragile. That's why it gets a whole bony case. Okay, next question. The most serious peripheral neuropathy is one that affects which of these nerves?
The autonomic nerves.
The autonomic nerves. Very good. Very good. Well, guys, we actually made it until 9 o'clock. I feel like I've actually earned my paycheck this time. I'm kidding. I'm kidding. Endocrine system, there's just not a lot. So last week we got off easy. There's just not a lot with the endocrine system. All right. So there is no quiz this week. However, there is your midterm this week. Midterms open in about 7 minutes and they will close at 6 o'clock in 1 week. So start of class next week. They will cover what we covered tonight, as well as everything we've covered previously: digestive disorders, endocrine disorders, lymph, immune. So study up, please. Any questions? All right. If you do come up with any questions, shoot me a message on Moodle and I will try to get back to you as soon as I can. Otherwise, you guys enjoy your evening and I will see all your lovely faces next week.
Thank you.
Thanks, Dave.
Thank
My
you.
pleasure.
Have a good night.
You too.